John?
Thank you, Consuelo. Thank you to the committee and to the study staff for the opportunity to present today. Sage Bionetworks, we're a nonprofit biomedical research organization, and we were founded with the idea that the roles need to begin shifting in research so that scientists are more likely to share with each other, but also so that participants can be more directly engaged with the process and have more agency. So that part of that is in the actual asking of questions, forming of protocols, but part of that is also in the return of results. And I have sort of three overarching points, and then I'm going to go into some of the experiences that we've had. The first is that this is a panel talking about meeting user needs. There's been almost no conversation over the last 2 days. I was watching the webcast yesterday. I apologize, I have a double ear infection. If I seem cranky, that's why. But there was almost no conversation about how design works as a way to meet user needs. So when we meet user needs anywhere outside the health system, we start with a design process. And that typically looks like, at the beginning, it looks like ethnography, but then there's a process to translate the interviews that you get. Consuelo is very familiar with this from her work in cognitive salons and cognitive interviews, where you can translate those into actual needs that you can feed to a product team. And that loop almost never gets closed in the health and medical research enterprise because we don't prioritize design, except in the context of study design. We don't ever prioritize user experience or interaction design. If you do that, what you can come out with are not rules that work every time for returning results, but some heuristics that you can use to begin thinking about any specific project, how to return the results. And then ideally a process for adaptation. So that you can actually implement those heuristics locally. So design to create heuristics, and then think carefully about how to adapt those heuristics to a local project. So at Sage, we run a suite of mobile-based clinical studies. They're not omics-based, but we've enrolled over 200,000 people in those studies in the last 2 years. We give everybody all of their data back. We also give them a dashboard that they can use to look at the trends of their data over time. We've also been very fortunate. We're the subcontractor for the All of Us research program, working on the ethical protocol and the informed consent and the return of results processes for the Precision Medicine Initiative. So what I'm going to sort of talk about comes out of those experiences. First is the consent document itself. Heard a lot about this over the last day. It needs to be written at a 4th or a 5th grade level. We use iconography and pictures inside the consent document to create visual breadcrumbs so that people can connect complicated concepts with pictures, and we can use those pictures later to call back and refresh memory. We prioritize a set of principles and heuristics. One is we want to minimize information overload at any one encounter. Second, that we want to minimize informedness decay over time as people get farther away from the consent moment. So we do that by creating tiered and modular consent systems. We don't expect people to read 25-page consent documents or to comprehend transferring their electronic health records and doing sequencing in the same consent encounter. So by separating these, we can make them a little more user needs centric. They can sort of take a bite of the apple as they want to go. It also creates the capacity for multiple engagements before they get a result returned. So you don't have to sort of deal with the whole thing the moment you return the genetic result, because they will have already been through a series of consent encounters and teaching interactions before they ever get to a result. Next is we really focus on the informedness part of informed consent, not on the consent part. Getting a signature on a contract is relatively easy. Trying to actually create a state of informedness is actually very complicated. There are, again, some ways that you can do better than the existing system. I'm not sure there's a perfect way, but there are ways to do better. One is visualization of the essential concepts in a consent document. In addition to writing the consent document effectively, not making it primarily about limiting liability, but instead about teaching. If you pull out the essential concepts, you can use design lessons from the web and from places like BuzzFeed, where we know that an on-task picture, a headline, and a subheadline actually slow down eye gaze fixation and slow down reading time to a point where there's a plausible opportunity for informedness to occur. Second, we provide assessments. These are not tests that you have to pass. We don't require 100%, but asking people questions, feeding them back whether or not they got the answers right or wrong is again a way to do a process of informing that can happen at scale, to Julia's point, through technology systems. For genetics, we're looking at things that are even a little different. We're looking at something we call the ballot box, where we could give people a set of statements about sequencing and ask them if that makes them feel better or worse about going ahead with sequencing or results return, as a way of provoking uncertainty in the individual instead of just trying to test them and see if they know what DNA stands for. And then we can say, you said, John, you said basically that you're only 10% comfortable with moving forward. Are you sure you want to get sequenced? Are you sure you want to get your results back? So that we can provoke some of that uncertainty in people. And then last is a way to provide longer-term support in these kinds of studies. We've run into the same problem Julia laid out about a lack of genetic counselors and genetic counseling resources. So how do we learn from other places where we have increased capacity? So we're looking at things like office hours, where you can have, for any given study, genetic counselors who sit in office hours and can answer anonymous questions from people in the study. We're also looking at ways, some inspirations from the biosafety community, where you also have a small amount of biosafety experts and a lot of weird stuff happening in synthetic biology, where you can quite literally go to a web page that says, ask a biosafety expert, type your question in, and the question gets syndicated to a list of biosafety experts who've agreed to answer questions. So in all of these cases, the idea is if you take a creative and design-based approach, you can start to develop these sorts of heuristics and adaptations that make it possible to achieve sequencing and consent in a much more informing way than a traditional consent interaction, which is where a clinical research professional presents a participant with a form written by a committee and vetted by lawyers. And if you get out of that environment, you can do an enormous amount of work around informedness, and that starts to set up the results return. Once we actually get to the results return, we believe pretty deeply that there needs to be an unlocking interaction where you take someone with a non-risky, non-ACMG style genetic result, something like cilantro or photic sneeze reflex or what have you, and use that as a proxy interaction to teach people what they're going to see when they unlock a more complicated, a more troubling kind of result, and then at that moment provide them the opportunity to reach out to these distributed kinds of counseling resources. And I'll stop there so we can get to the discussion.
Great.